Please help me welcome Dr. Ed Bertram as he discusses how to best prepare for your next visit to the doctor.
Thank you, Sophie. Can everybody hear me? Okay, good. So this is actually in terms of as it's prepared, is a very short talk in terms of material, because mostly what I also want to do is to hear from you all about your questions that you may have or issues that you may have come up with in working with your doctor or talking to the doctors that you may have seen. Okay, so this is, in epilepsy, as you all know by now, this is a very dynamic and interactive kind of a relationship that you have with your doctor, or should be, in terms of finding solutions and figuring what way to go forward to provide the best quality of life you can when you have this disease. So when you talk to the doctor, let me see, next, yes. You know, there are different, with epilepsy, there are different stages in the course of the disease that you go through, and how you talk with the doctor really depends on where you are in this journey. For a lot of people, it's just the first time you've had a new onset of seizures, and they're just sending you to see this neurologist, and what should you be looking for then? What kind of information is he looking for to get things started? Because it's very different than when you get or later in the disease, when things are going fine or things aren't going so well. And we're going to sort of mostly focus on what happens when things aren't going so well, and then I'm going to depend partly on your experiences too, to say, you know, this is a problem that I've encountered in trying to address the physician or whoever you're seeing for this. So, you know, new onset seizures, follow up, things are going well, they start on a treatment and the medications are working, whatever they're going. But then for a lot of people, the things aren't going so well. It's a follow up, but so how do you then address those things that are bothering you that are still a problem, whether it's still seizures or medication side effects or whatever? How do you approach this, the doc with this? And then finally, if the seizures really haven't been controlled and you're referred to an epilepsy center, what additional information is going to be helpful to the physicians to perhaps pick out a better course for you? And it's quite variable from person to person. So usually, especially if it's a new onset seizure visit, the doc just really is interested in a couple things. What happened? What did you see or what did you feel when this event happened? Because at this point, people still aren't sure whether this is a seizure or not. Something happened to you and you're looking for an explanation. So what happened from the very beginning to the very end? How long did it last? A few seconds, a couple of minutes, some hours? That's, all relevant information that you should take along. And also, how long did it take to recover? And recover is kind of a quite variable situation in that for some people, they're completely back to normal within a few minutes or less. And other people, it can take a while. And sometimes that recovery isn't obvious because they might be talking to you normally, but they can't remember anything from the conversation for some hours. So, what is the recovery? Because that also will then give the doc an idea about what might be involved, what's going on, and how likely was this to be a seizure as opposed to something else. And the other question is, how often does it happen? If it's a one-time event that you've had, that's what you want to let them know. But if, in retrospect, there were some things that were happening before that, roughly how often were they going? So just before you go, think about your past history and what might have been unnoticed at the time until you had the bigger event that got you to the doc. So for us, when somebody comes to us, we really look for a couple of things. And oftentimes you will hear, it doesn't sound like a seizure, but in fact, just about anything can be a seizure. And I think that's the important thing. And even for a lot of neurologists and general physicians, they have this image of what a seizure should look like. And they sort of, well, that fits my image or it doesn't. But it's actually, the image are often wrong. But, the key features that we look for when we're talking with somebody about questions, are these seizures? Or is this epilepsy? Did it happen, seem just out of the blue? You were just going along fine, and all of a sudden this event hit you, and nothing that you can point to. And then for the epilepsy side of things, does it recur? Does this happen a couple times? Because with a single event, it's always hard to say, was this really a seizure? Or even if it was there a cause to it? Or is it something which is something entirely different, and it was a one-off event? We're also looking for, are each of these spells the same? Because we said it before, with a lot of these things, the issue is it doesn't really fit the picture of a seizure. But I've seen a lot of very unusual things when people have seizures. One patient had just leg scissoring during her seizure. She could talk with you, everything was fine, but she just had this recurrent episodes of leg scissoring, which turned out to be a seizure. Fits nobody's picture of what a seizure looks like. But it's that idea that this keeps coming back, and it's the same every time. Puts a much higher risk that this is likely a seizure. They have to have a clear beginning, and then they stop on their own. So those are kind of the things in taking the history that we look for to say this is fitting more and more into the likelihood that it's a seizure and possibly epilepsy. So, but that's the issue. When somebody comes to us, and this is what I tell my patients, is that from the information that you're giving us, it could be epilepsy. For most people with the disease, that's as close as we get, because there's nothing short of actually seeing it and recording an EEG during this that'll tell us for sure that this was a seizure. And so most of my patients over the years, we have this, it sounds like a seizure, and let's go forward with it with that in mind. You always hear about the tests that you get. They come in with these spells and they order an EEG, a brain scan. And what are they for? If I can make the diagnosis a lot of times just by the history, what do I need these tests for? And part of it is, if it's a seizure, the EEG patterns are different from different types of epilepsy. But people with epilepsy can have very normal EEGs in between their seizures. Sometimes even during the seizure, the EEG can look pretty normal. So, but it helps us say, it's this kind of epilepsy, we might use these kinds of drugs, or maybe a different kind. But we never exclude or include somebody with epilepsy just based on the EEG alone. You also want to see if they're having these spells, which are possibly seizures, what's causing them. Can we find some abnormality in the brain scan that may be the source of the seizures? Not guarantee that it is, but could be the source. And some of those sources are things like small tumors or things like this that you might want to treat earlier rather than later, just because it may cause problems beyond the seizures down the road. So is there something there which we really need to look at more carefully early on? Or is there an abnormality there which said, these are possibly seizures, but this thing here we're seeing on the scan says it's more likely that you're going to have one. Again, none of these are clearly diagnostic, says this, you have epilepsy for sure. It's based on the history. And even as I said, when you record them on EEG or see them, you don't know for certain. There's a couple studies done, people who had psychogenic seizures versus epileptic seizures, and they were asking the docs, can you tell the difference between the two? And the answer was no. It was a 50-50 proposition, because there are some strange symptoms which happen with regular seizures, and some of the non-epileptic seizures can look very much like an epileptic seizure. So even seeing it is not a guarantee that you're going to get the diagnosis right. And I think from the clinician's perspective, being in this field, is that we're often wrong. And it's keep that in your mind when you are being seen in follow-up, that, do we have the right diagnosis? Because it may not be. So, for folks who come in, these are the questions that most people ask. Why? What's causing these things? Sometimes we can tell, sometimes we can't. Can it be treated? Usually, yes. Will they go away? Sometimes. And I think from the patient's perspective, that's one of the great frustrating things. You know, how is it going to do when you give somebody medicine? And it really depends on the person. And we said, yes, likely we'll be able to treat it, and maybe it'll go away, maybe it won't, but we have no idea of getting started, with a few exceptions of some childhood epilepsies that pretty likely are going to go away with time. But most of these things, we don't know if this is going to be a short-term course of disease or it's a permanent issue. And we just said the usual answer we have is the longer you go doing well, the more likely it is you're going to keep doing well. And that's sort of the reality of the disease. And it's frustrating because we can't say the future looks like this. It just says, you know, as long as things are going well, things are going well. And so that's why sort of the dialogue happens between the docs and the patients. But I think, you know, in most cases, when someone comes in, we start the treatment. If the seizures stop, we're all happy, and life goes on. And that's sort of, that's how much, even the fact that it got better doesn't even tell you that it was a seizure or epilepsy. But because they're not happening, we're not too worried about it, because they're not happening. So, but this is sort of in the first stages with the disease or with epilepsy. But as time goes on, it might change. But when you first come to the docs early on, you have the description of the seizure, which is what you want. Did you have any symptoms that precede the seizure, sort of warning signs, that aura? Is there a family history? And if you've been treated before, how well do the medications work? And how they affect your quality of life? But also for people, this is one of the important things to bring, is that when you see the physician, especially if the seizures aren't doing well, you want to keep a calendar of how often, when the seizures are happening, how long they last, time of day, because then that can give the physician a better idea of how well the treatment is working. Most people, when they come to see me, if they're not using a calendar, they remember the last seizure they had, and maybe the one before that, but after a while it all kind of fades into the past. And they can't remember, did I have 5 seizures since the last visit? Did I had 2? I just remember really the last. I think there might be a couple more. But bringing the calendar in also tells us how well we're doing with the treatment. And sometimes we're doing better than the patient thinks. And sometimes we're doing worse. And that calendar will help us to decide where things are going and what we might need to do. So this is some of the basic information that you really want. A lot of this, like family history, isn't going to usually change our treatment immediately, but it'll tell us, you know, what are some of the likely contributing factors to it and what the risks may be. But then the things are when things aren't going so well. For us, in all the reports, for the physician, what you think is, all we really focus on is the seizure count. How many did you have? And if you're not having any, we feel good. We would be in a mission accomplished. But as patients have told us, that there's more to epilepsy than the seizures. And it really comes down to how are the medications affecting you. One of my first lessons in this was many years ago when there was a 8 or 9-year-old child who came brought in by her mother. And she had been diagnosed with absence epilepsy in another town before they moved to Charlottesville. And the mother made the observation that, they diagnosed the absence seizures, put her on Depakote, the seizure stopped, but she went from being an A student to a D student. And her thought was, the seizures were better than this, stopped the medicine, the absence seizures came back, but she was an A student again. So one of the things that we always want to know is, how are things going in general? Because we hear a lot from patients that ever since, or the families, that ever since the seizure started, things haven't been doing so well. But in many cases, it's not what's happening to the person, it's the consequence of the medicine. And so those are the things that we really want to know about, and you need to pay attention to. Some of these changes are not necessarily noticed by the person taking the medicine, but by his nearest and dearest. And the most common one of that is with Keppra and the well-known Keppra rage, and people really have a lot of mood disorders and behavioral disorders. They themselves will feel fine. They say, no, things are good. But you talk with the family, and no, things aren't doing so well. And in fact, life is pretty terrible since he started this drug. And so you want to then pay attention to that, and you have to tell them, if you're focused entirely on the seizures, you're going to miss some of the things which are far more impactful on their lives and the lives of everybody around them that you really need to pay attention to. So always when you come to see the doc, it's important to say how things have been going. And there's another piece of this is, in many cases a person has a seizure, they get started on a medicine, seizures stop, but the family kind of says, ever since these seizures came along, just not been himself. There's just something different. And they sort of assume whatever it was that set the seizure off was the culprit here, but it's really the medicine. Just that seizure happened, so they're looking at the seizure happen, and this is a consequence of the seizure, but it really is a consequence of the treatment. And just be able to tell that to the doc and pay attention to it. And I think probably the third point here is really important, and this is for you in more cases when the patient has been on treatment for a while, is what are the things that are important to you in the treatment of epilepsy? Because for a lot of people, they'll tell us that, we're still working on the seizures, trying this or that, and, we'll hear from the patient or from the family, the seizures, they're not that big a deal. I can live with this, but it's these other things that are a real problem for me. And that's, I think, this focus on the seizure count is something which is it's important, but it's not the only thing here. And it gets down to the quality of life for people, family and the patient. And so that's one of the things to pay attention to. If you're going to see the doc, you can sort of say, seizures are okay, but these are some of the concerns we have. And people think that we've got to treat the seizures, but that's not the case. Just like that little girl with the absence seizures, her seizures were not getting in the way that much. They're minor irritation, but the medicine certainly did. And so it's important to sort of say, ever since we started this, school performance has gone down. And a number of folks that I've seen over the years would say, I had no idea the medicine was doing this to me until we stopped it to, do EEG monitoring or something like this. So I think it's really important to sort of pay attention to those other factors in this that really impact the quality of life most. And I think the important thing to remember is that in treating epilepsy, seizures are important, but the overall quality of life is every bit as important, if not more important, because you're going to live that way. So when you come to the visit, it's important that you bring the information with you, sort of have it jotted down somewhere, because, when we're talking with somebody, we're going, it's sort of like when you go to the grocery store, you made a list, but there are a couple things you didn't put on the list, and then you walk out of it, you're going to get them, but all of a sudden you forgot. It's the same thing when you go see a doc, is that there were a couple things you wanted to talk about, but in the discussion back and forth, that just kind of got forgotten, and you walk out without it. So have that list to say, these are some of the concerns that we've got in here, and how should we address that? Because those are the things that are important to you, and those are the ones that really need to be addressed. And it can be educational issues, it can be social issues, it can be employment issues, a lot of things that are far more important than the seizure count per se. And that's, you need to make the doc aware of that. So, but there are a lot of things here that people don't think about that really also affect the treatment and the outcomes. So this is especially if you're seeing a new doctor, or the things that have been going on haven't been going so well. And one of the biggest issues these days is most people are on generics, and they're fine. But the generics are made by, in many cases, a dozen different companies. The medicine that's in the generic should be fine. There's no evidence that it's not. It is what it is. But every pill is got the medicine, but it's got a bunch of other stuff that's used to glue the pill together. And how the pill gets glued together has a big effect on how it dissolves when it gets to your stomach and gets taken up into your bloodstream. And it's been a big issue in epilepsy for a while, and I think people are beginning to recognize that changing from one generic, it's not that one company is better than the other, that this is the one you want to be on. But what you want to be on is the pill from the same company every time. With a name brand, that's not a problem because it's whichever company it's coming from. But with generic, it often have the situation in which it's coming from company A one month, then coming from company B in another month, then a company C in another. And levels can do all kinds of funny things. And my own patients have noticed this. They came to me and said, I was doing well, for a long time, seizure-free. Then I just got a better price from this other pharmacy, and I went over there, and the pill changed, and the seizures haven't been under control since. And we just changed him back to the original generic that he'd been taking, and the seizures went away. And so it's one of the questions I often ask the patient: have your pills changed? No one's paying attention to whether it's from this company or that, but do the pills look different? And sometimes they'll say, yeah. And you can see in their seizure calendars, the importance of seizure calendar, some months are better than others. And so I just tell everybody if they're on generics, to jot down the name of the company. Usually for most pharmacies, you're going to see this little thing that says manufactured by. It'll be Taro or Torrent or Aurobindo or Unique, a whole bunch of different ones. But just make a note of it. Because what we can do then, and this is kind of becoming more of a recommendation, when we write the prescription, we can say it has to come from company X. And then the pharmacy is then obliged to fill that prescription that way, and that then usually things settle out. Every now and then the pharmacy will say, I can't get that one, and that's a bit of a panic because people have had problems with other generics, but that's one of the key pieces of information that I would look for. If things are sometimes good and sometimes not, are they just changing the generics on you? Because it is a big problem, and it's well recognized, but it's something only you can tell us when you come to see us, is if the pills change and which companies seem to work better than others. So, and that's I teach that to the residents, I teach that to a lot of other people, and the message slowly gets in, but really paying attention to the source of generic is a big, big issue. A lot of people, you're well aware of, have been treated with the different things in the past, and then they were changed to something else. It's when you come to see us, it's really important that you first of all know all the different medicines that you've taken in the past, if they were stopped, why were they stopped, and also how much were you taking. Those are three things. We'll sort of go through each one. One of which is that it really did not help, and they pushed it all the way as far as they could, and it really wasn't helping, and so it was changed to something else. But a lot of patients that I've seen over time, they still tell me, medicines they were on, and then they said, well, I asked, why was that stopped? And they just said, well, doctor said I shouldn't be on it. And there was no clear reason. They were doing okay. The seizure was completely under control, but they were doing okay, and the doctor said stop. And that can sometimes be a big issue because for a lot of physicians, they sort of have this image that you can only use so much of one drug, of a particular drug, 5 pills, 6 pills, fewer, and then if it doesn't work. and you got to change it to something else. The reality is, as I tell my patients, there is no upper limit of how much you can take other than you come to me and you say, I can't live like this on this new dose. Or you call me up and say you can't. And that just tells you we really have maxed out that medicine. But what the upper limit is for some people is hugely variable. You've heard with Keppra used. I have some patients who had problems with Keppra when they were taking 1,000 milligrams a day, which is a low dose. But I have other patients who are on 9,000 milligrams a day, and they're fine. That is way above the recommended maximum dose. But they're feeling fine, and it's doing its job. And the message is, for all of these medicines, is that the only maximum dose is the dose that takes you to the point of you having side effects that you don't want to. Otherwise, you can keep pushing. And I have some of my patients who are on very high doses, and they're doing fine. They're not having a problem. Even their levels are toxic, technically, but they're doing fine. And so the message is, with these medicines, were they taken as far as they can go? And oftentimes the case is not. But I've had other patients over the years, so I asked why a drug was stopped. And he said, the doc said I shouldn't be on it. How are you doing? I was doing fine. The seizures were under control, but they just told me I shouldn't be on it. And usually there were times where scares where medicines were, well, you shouldn't be using this group of medicine. But the evidence for that was pretty weak. And you just wanted to say, well, sometimes we go back to that after we tried all the newest and best things, and it actually is the best medicine they've had. So I think one of the things to remember in all of this is that, understanding, because this is what helps us when we're seeing you if you're your third referral or whatever, to say, what are our options? And we go back and say, no, I was doing okay, but the doctor just told me this is not a good medicine to be on. And then we have a further discussion about that. So that's why the list of what you were taking, how much were you taking, and why it was stopped is really important information to bring. Because we get a lot of that, where they would just stop. They hadn't been given an adequate trial of the medicine before it was changed to something else. And that's practice differences, but tell us how much you took and say, we can go a bit higher than that. Everybody's worried about how much they're taking, and you really shouldn't worry about that per se, other than what the effects it's having on your pocketbook, but is really how are you doing on it? And that's it, because everybody's different. They handle the medicines differently, and it's really individualized treatment. Also, when you come to see us, we want to know what the previous test results were. You should just have those with you. But I think this is the biggest thing here is that the treatments you're on in the past, whether you've been switching generics or not, how far you've gone, why a medicine was stopped. If you had a major allergic reaction, no, we're not going back to that medicine. On the other hand, there was not a clear reason why, other than that you were told it was time to change, but you're doing okay. We might think about going back to it. So just sort of keep that in mind as you go through, what the options may be. So these are some of the questions that we look for and some of the information in terms of deciding how to go forward. I'm not getting into the issues of surgery today. You've heard other lectures about that. But I think the most important thing, when you get to go see the doc, make your list of priorities. What is it that's important to you? Because that can then help you and work with the doctor to sort of decide, what do I want to emphasize here and what is not important. And quality of life issues are every bit as important as the seizure count. And it's become an issue in epilepsy surgery where the emphasis has always been on how many people are seizure-free. But it has not, they don't look at necessarily what's the quality of life for the people after they've had surgery. In some cases, it's great. They really are doing amazingly well. But in others, they sort of think, maybe I shouldn't have had the surgery. Yeah, the seizures are better, but life just isn't quite so good since. I mean, I'm talking, walking, all those things, but there's just something about it that's different. So, this really comes down to how do you want to live, and how can we get you there? What are the things which are important? As I said, and a lot of other people have seen too, that a few seizures every now and then aren't particularly interfering. Is not a big deal if the treatment to get you any further than that is really going to cost you a lot. in terms of just your quality of life. And just keep that in mind. You're the only ones who know what's important to you. And we're making changes in how we're trying to treat this. And you've got to sort of let us know what that is. And more than once, I've had a patient say, for about a family member, the seizures, they're not a big deal. And, we don't want to keep chasing things. We're satisfied with it where it is. Life is not going to change considerably if we get every last one. These are people who had, a couple of seizures now and then. But life's not going to change a whole lot one way or the other. And so we're at a stable point. Let's stay there. So that's kind of an overview about how you might want to set up what kind of information you need, what's going to help us to then work with you to get the seizures and epilepsy and quality of life where you feel better about it. So, questions, comments, concerns? Yes, ma'am. Okay. Mm-hmm. 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 That is, you say just that. You start off with it, and just like with the diagnosis of epilepsy, it's based on a lot of the symptoms that you tell us, and we often will start a medication, and the answer will be, well, let's see how it goes. And if new things are coming along because of that, then maybe that wasn't the best choice for you. I think one of the things that a lot of people are sometimes afraid to say is that this pill you put me on, it's not helping and it may be causing problems for me. And for things like ADHD, I mean, it's important to treat, but there are other ways to treat it, and it's got to be how much this is impacting your life. I think the criteria for ADHD too are often pretty nebulous. I know many years ago our son was diagnosed with ADHD, and I think he decided after a while that it really wasn't his ADHD. It just wasn't. He wasn't interested in the things that he was supposed to be interested in, and so he wasn't paying attention to them. He was easily distracted with something else. So I mean, this is not to make light of the diagnosis because it's a real thing, but it's how much is it getting in the way? There's a lot of studies about people worried about using the stimulants for ADHD in people with epilepsy, and that might cause the seizures to get worse. There's no evidence that that's the case, if it helps, it helps. But if it's not helping, then, deciding what the symptoms mean, which I think is that's not always easy to tell, because just like with panic attacks, and there are a lot of symptoms that are similar to the onset of a seizure for some people as the onset of a panic attack, and it's really kind of, unless you are monitoring somebody or strong evidence otherwise, it's really not possible to tell. So you make some adjustments in your medicines, and then you see, how things go with that. And if you stop the medicine and it gets better, and then, or some of it, then you might want to think that it's something else that's there. Okay? Yes, ma'am. Uh-huh. 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 Well, the first thing you do is you sort of tell them that this is just not, this is not what we want for life. And the question about when after surgery should you stop the medicine, can think about it, there is no good answer, and there's not a lot of evidence to show that waiting a while versus doing it right away makes a difference. I mean, I've had patients in the past who, shortly after they had more traditional surgery, and before they came back to see me, stopped the medicine on their own. That's not what I would have recommended, but it worked out just fine with them, and they did well because they just didn't want to be on it. And the question is always, well, does keeping on the medicine for a while longer prevent the recurrence of the seizures? And there's no evidence that it does. The tendency to have the seizures is still going to be there, whether you stop early or stop late. So, but I would let them know and just sort of say it may be a simple dose reduction right off the bat. But that's you should let them know. Well, again, some of my patients didn't let me know, and they turned out okay. So, but it's that's the sort of just let them know you're going to do this or this. Which one? If he's on several medicines, then you can decide which one might be the greatest culprit. But there's no right or wrong way of doing this, it's I think when even for any such circumstance, when you come down to the issue of stopping medicine, whether it's 10 years, whatever, or right after surgery, the conversation that we usually have is patients fall into two groups. One group says, I really want to get off this medicine, and I'll take a risk for having a seizure just to see if I can get off of it, because I really don't like the way it makes me feel, or I don't like taking it. The other group says, I'm feeling fine, the medicine's not bothering me, I'm not going to rock the boat, I'm just going to stay where I am, because there's no way we can say how you're going to do once you stop it. In this situation, post-surgery, I would just let them know that this is what you want to do, and think about if there's several medicines involved, which one might be the biggest culprit. In some cases, the drugs that are sedating, not for all of them, but there is a risk, especially if you go too quickly, that you can have withdrawal seizures, and that'll then freak everybody out because they think that it didn't work, but just because the medicine was coming out of your system. That's not true for all medicines, but usually they'll say, work on a program for cutting the dose down as well. We'll let them know. Yes, ma'am. I think, it's always bothered me when patients come to me and they've really been subjected to scare tactics. If you do this, your brain's going to dribble out of your ears or, whatever. And it's generally not true. And, if that's the case, it's very difficult because you're dealing with variations in personality. And I am not an expert on that, but it's you got to make it clear, and if it's a physician who is put it kind of in very stark terms, my way or the highway, then it's time to probably see somebody else who will listen, because I think especially with epilepsy, it's a situation where there has to be a two-way discussion in there about what's working. And you talk about what are the risks, and there are times with my patients we decide to stop a medicine, and things didn't go well, and we went right back to it. But in many ways, the only way you find out is by making the change. And sometimes it's a good change, and sometimes it was not such a good change. And you just sort of have to be prepared for that. When someone's on 3 or 4 medicines and we want to get them down off of something, or if they are having side effects, the truth is we don't know which is the culprit, which one is, because sometimes it's all of them together helping or all causing problems, but you kind of take a deep breath and say, let's try this one for these reasons. It never seemed to help to begin with, and I think it does patients a disservice if the approach is just to keep piling medicines on, because that's when the side effects begin to mount up, and you don't know anymore which one was good, which one was bad, and usually you try to say, put an upper limit, and then sort of work to getting you on for different medicines as you can. But I appreciate that, and in this case, it might be worth seeing someone else too. Okay. Yes, ma'am. Most of the time, on the bottle that you get, the prescription with the pharmacy label on it, most of them will have manufactured by or something like that, and there'll be a name of one kind or another. But if it's not, ask them. Pharmacy, they're required to keep a record of, because if there's ever a recall from this manufacturer, they need to have that on record with your pharmacist so you can ask for that. But it should be on the bottle. I've seen a couple of pharmacies that it doesn't seem to be on the bottle. Then what we do, there's also sort of a pill identifier. You go online and you sort of say, whatever drug it is, and you can get a bunch of pictures up, and you can match the numbers, the shape of the pill, everything else. You can say it's from this company. And patients and I have done that before, just to sort of just gone online and they've got that available. Yes, ma'am. In your face? You just ask, and actually the way the rules are now, you own those results, and so you should be able to get them, and they can't put you they can't stop you from doing that. It's actually a violation if they refuse to give it to you. Okay, so I know at UVA, the patient have access to their records online, and they can pull it up. So yeah, no, you should be able to get that. Okay. Back in the back. That's always a touchy subject, and when my patients sometimes feel guilty when they ask about going to see somebody else, and I tell them they shouldn't. If things aren't going well, you just want to say, go talk with somebody else. Maybe they'll have a different perspective than I do, and it's not a big deal. Somebody they'll learn something and that I didn't know. So it's fine to do that. Also, what you can do if you're seeing a neurologist, you can go talk with your primary care physician and ask them for a referral somewhere else. And so you don't have to initially go through that. Some people are very sensitive about it, but this is ultimately you, and you're looking for answers here that aren't going to be. Sometimes they're not going to be any easy answers, but having a different opinion sometimes, and it's happened, is they sort of will reinforce what your primary neurologist is doing, which is also gives you some confidence in this. So it's perfectly, from my perspective, it's perfectly normal to want to do that, and it might be easier just to have your primary care refer you somewhere else. Have a rough idea where you want to go, because probably for most primary caregivers, they don't know who sent you to neurology for epilepsy, and so you look around and see what and often we've talked about it here with Candy and some of the others about having a little database of names, especially people who you would recommend. We can't really trash talk other docs, but we can at least put names up that they've had a good experience with. Want to see why you want to see if there are other options that not in my case there's certain things that I don't recommend to people, but they're out there in the literature and they would like to say stimulation or something that they've heard about it, and I'll just tell them, well, I don't do it, but I can send you to somebody who does. So it's up to you. It's ultimately you're making the decision for what it is you want to know, and if there's information that you feel like you're not getting, then it's fine to go. Or you've heard about things and you send somebody else to see if those things you've heard are they real, or is it somebody's fantasy? Yes, ma'am. You had a question. Have the right to those, I think, which is a good change. Yeah. Yes, ma'am. talk about rational therapy for a long time, about choosing just the right drug. And it started for a while, and the sad truth is that it is random luck. Sometimes the sad truth is that for most of these medicines, what works for one person doesn't work for another. They seem to have the same disease. And so it's just a matter of finding that. And sometimes, some patients can go through 3 or 4 medicines and there. And for other patients, we feel right off the bat. So,
And that's what I was kind of asking is just like if there's certain testing or certain ways that we can navigate that instead of just going down the list and seeing which one works best for them.
choosing a medicine, so when we have a discussion with patients, there's no logic to it. There's certain things, for, say a woman is thinking about having kids, I might use this medicine, not that medicine. For kids, I might use a different one. And so you try to put it in the context of that person and say, this will probably be the better drug for you. And, we choose it. There's also some that are a little more effective than others, but that's only, so there is no test, with a few exceptions, that tells you this is the drug for you. And it's going to work. We wish you the best, but it's not.
Because I know that we had I'm sorry, the fifth episode is certain things. And I just want to, like, that's why I was trying to navigate, trying to ask the doctor, like, how did you end up with this one now? Certain focus versus the other channels that were sending us the other information going after. Like, how do we know this was, are we just going to try all of
We're going
this?
to try them. So again, so sort of the person putting your history into context, that person's own experience with the different medicines and how well they worked. And there are lots and lots of sodium channel blockers, but how they work in each person is a bit different. And one sodium channel blocker will work great for you, but another one won't. And so it's that mechanistic idea, because not only do they have to work in a certain place, but they also have to get to that place in the brain, and we don't know how the drugs get exactly where they need to go. The truth is too that all we talk about that the drug does this or that, sodium channel blocker, GABAergic agonist, or whatever. When it gets in the brain, in most cases we're not sure where it works or how. We just know that we put it in a dish, it does this particular thing. When you talk about Keppra, they made up some magical thing about they have no idea how it works. It just gets in the brain somewhere, and they're just looking for some sort of mechanism to say that's it. So no, you're expecting more of us than we can provide. All right.
That was beautiful.
Okay. All right. Thank you all.